So we've spoken about the SLNB, SIBD. So now you have to do, the staging inguinal lymphadenectomy, DSLNB. So any special consent would you take before the total amputation of penis? Now that you have done the superficial block or the sentinel node, would you send it for frozen section? You would not send it for frozen section? Your thoughts, Dr. Srivatsan and Dr. Amit?
So special consent probably for a perineal urethrostomy since total amputation, and possibly that resection of the nodule there, and that will be sent again for a frozen. Always the superficial inguinal nodes in my center goes for a frozen to make sure that we have one, is it positive or negative, which will decide the future course of treatment in the same setting.
Would you want to wait for the final pathology and do it as a staged procedure?
No, sir.
Would you're a big proponent of robotic surgery here. Would you like to do a robotic veil here at the same time as doing the penectomy?
So as I said, I always do the staged procedure. So I do the penectomy first and then...
It comes out as high risk.
High risk, then I would, if it is a clinically N0 and image-wise N0, I will suggest a veil procedure is not a bad idea.
So what are the any disadvantages of veil that you could think of if you are doing a robotic veil here?
So the only problem with veil is that we do generally both the deep as well as the superficial lymph nodes. We generally do not do only the superficial, and they'll go on to progressively. So that could be a slight, I wouldn't say slight, increased morbidity due to over-treatment generally. So Perfect. In a general case, probably this guy would have got away with a superficial inguinal lymph node decompression, would probably have an increased risk of morbidity.
Exactly. So if you do a robotic veil, in most instances, it ends up as being an over-treatment for the high risk, because they would have needed only a superficial block dissection, but most of them end up doing superficial and deep inguinal lymphadenectomies. Dr. Sudhir is here. Is it possible to do only a superficial block dissection with the robotic veil? And I know you've published, you presented a paper on this also, so that's why I'm asking this question here.
We have a maximum series of
yes.
Thing, and it's not that you can't do superficial block dissection with the robotic veil. Only thing you'll end up in having more time. Because you remove the superficial, then you go on other side, then you come here. So that is why for convenience you do that thing. And there is hardly any increase on morbidity, especially if you are saving the saphenous vein. Only problem with the robotic veil is lymphoria.
Yes, sir.
And this is with open also. And in open we have tried everything, clipping, ligating, all the lymphatics, even then it occurs. So we are working on something, it may actually sort out some problem about this.
So we published a randomized control trial on clipping of the lymphatics after the open inguinal lymphadenectomy. What we do is inject methylene blue all around the incision, and wherever the open tips of the, wherever you can see the open lymphatics there, which, where the lymphatic ooze is there, with a surgical clip, we go and clip off, although the 200 clip, we clip it off. So we did a randomized control trial, 20 patients on either arm, and then we found out that the total lymphoria and the number of days that the drain is in situ for the clipped versus the non-clipped was highly significant, was far lower for the clipped versus the non-clipped. The lymphoria was also far less for the clipped versus the non-clipped.
Anyway, drain output, sir? Drain output also?
Drain output was lower. The number of days that the drain was in situ, and the total lymphedema for the limb. The final lymphedema was also different. We've also had some patient where one side we've clipped, one side we've not clip, that's the way the randomization came in.
How much the difference between days on
what clip was 3 days, 2.5 days.
When you clipped?
We clipped, it was lower by 2.5 days.
The approximate number
the lymphedema was also lower in the clipped versus the non-clipped.
What was the approximate number of days used to keep the drain in clipped cases?
I don't exactly remember. I'll pass on the paper to you.
Dr. Sudhir, sir, how many weeks?
I'm not sure. I know your question, and you're asking how is it that the final lymphedema was lower. It should technically not be lower, but it was. So we did not publish the results because the trial only looked at the number of lymphoria and the number of days that the drain was in situ. But we've looked at the final lymphedema of both the limbs after surgery.
1 year, I think you'd have to wait 1 year.
Sir, we've already published this paper about 2 years back. The lymphedema was not part of the study. We've looked at the lymphedema later on. We are going to publish it now. We've collected the data. The final lymphedema is lower for the clipped arm. I don't have a reason to explain why it is, but it is. Maybe. So going on. So the on-table plan, what we did is the total, the frozen sections, these are the biopsy reports. The frozen section from both inguinal regions came out as positive. The nodule at the cut end of the urethra shows tumor. On-table plan. Dr. Shivatsan.
I would proceed with the complete urethrectomy with corpectomy, which is the radical penectomy.
So will you do only, Dr. James, would you like to differ? Now you already know there is some nodule in the urethra, so on and so forth. Would you tell Shivatsan just do the inguinal block lymphadenectomy and leave it at that nodule which is positive in the urethra that can come positive later on also? So I might as well just radiate the entire area at risk.
I think we
It's
started.
a skip metastasis in the urethra.
We started with T2. Now we have gone very, very.
This is a real case.
very
This is
difficult,
there
yeah.
is nothing that is surrogate in this.
So we have gone to very higher stages, so it has to be very aggressively treated. And I understand that surgical treatment is a good way to deal with it, and then maximal aggressive approach with chemotherapy and radiation.
So I think we got very lucky here. The plan was we had completely disregarded the nodule in the urethra, except that we have to send it for a frozen section here. And we were in general discussing in the ward that, you know, where if it comes positive, we have to do a total prostatourethrectomy, so on and so forth. After the nodule came positive, and I was just sitting there, sitting dumbstruck as to, you know, I have not taken consent for this, and my postgraduate comes up and says, oh sir, you were talking about all of these things, so I have already counseled them, I have done everything, and that's it's on paper here, we've already taken a consent for the prostatourethrectomy. So we got very, very lucky with our postgraduate here.
Would you think of a scopy at this point of time? Would you do a urethroscopy?
The MRI was already done. I mean, the MRI only showed you the representative
What if this
images,
says-
but the MRI was already done for the pelvis and nothing was there, so that was already seen prior. So what we did is this, sir wanted to say something, I think.
No, this after prostatourethrectomy, what did you do for diversion?
So we just put in an SPC, we closed the bladder neck and then we just did a final, an SPC, a permanent SPC.
I think the option is not to do the SPC. You can go for metrophenol.
Yeah,
You can
could
put
have been done.
appendix, or you can take a bladder wall, or you can go for
Continent
Daniel
diversion could have been done.
Yachia's,
I agree. That would have been a very viable option at that point in time. So again, now the biopsy is there is sentinel nodes have been done. 4 nodes have been sent for biopsy. On either side, 1 node is positive. Would you want to do only the inguinal lymphadenectomy, or would you like to do the ilioinguinal lymphadenectomy and then what else, what not?
The ideal would be to do a deeper node and then send it for frozen again to think. But considering the fact that this is probably a T4, probably I'll think about an iliac as well.
Yeah, so what we did is we did an ilioinguinal lymphadenectomy. That's what we end up doing most of the times, because as per recommendations, it should be more than 2 nodes or any perinodal spread. Then you have to go back and do the iliac lymphadenectomy, which is again a secondary procedure. Here we have already opened the pelvis. The pelvis is right there. There is very little option to go back again inside again. So we've done the ilioinguinal block lymphadenectomy.
So I have a question. I mean, so the way the stage is being changed now, and the disease, the way it has come out to be, the lymph nodes, bilateral inguinal lymph nodes are positive. Still, will you be
the biopsy is there.
No. So reconsidering your, like we started all the treatment with just with a chest X-ray. So would you like to again go for some other imaging, because just chest X-ray and ultrasound, will that be enough? Or you
So
want to go
in
for a
our
CT
own
scan now?
experience, we've done a fair bit of penile cancers. So in the absence of gross retroperitoneal nodes or gross pelvic nodes or multiple pelvic nodes, yeah, the X-ray chest, until and unless you see something else there, is sufficient most of the time. We've reviewed our data for about 1,000 patients on penile cancer, node positive about 700. Very, very few patients have had chest X-ray normal and then have had some other lesion. Only in the presence of bulky inguinal nodes or retroperitoneal nodes would there be an increased risk of pulmonary metastasis. But that having been said, I agree with you. That would have been a good investigation to have. Outside of an institutional practice, a CT chest would have been a very good investigation
I
to
think
do.
we should go for a CT chest. And I mean,
In a clinically node negative, the role to do a CT chest would be a little remote. Anyway, going further, we have, I have a very strict
How
timekeeper
about a
here.
PET CT? Would a PET CT would have?
Sir, a PET CT scan for a penile cancer, the role is more investigational until and unless there is a suspicious nodule or suspicious sites elsewhere. The role for either primary staging or metastatic staging in the upfront setting, the data is very limited. Dr. Sudhir has some role to play.
Early CA penis, it overstages. It's actually fallacious.
Exactly.
You will see the node positive on PET CT. When you operate them, they are negative.
Exactly. So it
But in
doesn't help
advanced
either in
stage,
staging of the
definitely it
primary
can
or the met. So that was the biopsy report now. 6 of 39 nodes were positive. Perinodal spread was seen. One pelvic node was also positive now. One pelvic node on either side with perinodal spread. So 2 inguinal nodes on either side and one pelvic node on either side with perinodal spread. Dr. Amit, he's been quiet for a very long time now. Now we've done our part, everything else. Now the patient comes to you. Patient is being discussed in an MDT. Dr. Amit is here and Dr. James is here. Dr. Tanveer is also here. The plan for adjuvant therapy for this patient.
Before that, one question which comes in my mind, that the probability of being a retroperitoneal node, have we done a CT abdomen pelvis?
The MRI included, because we got an MRI done, we also got an MRI of the upper abdomen done. The retroperitoneum was clean. In fact, pelvic nodes are also very small, 1 centimeter nodes.
So if we are assuming that there is as such no metastatic disease, the
We are not assuming, we know that there is no metastatic disease.
but it's a disease which will come back in 1 year, 1.5 years, that I'm sure. Seeing
Yeah, so-
see a penis patient.
So that's why you are there. Two inguinal nodes on either side. So 4
a bad
inguinal nodes
disease.
and 1 pelvic node on either side with perinodal spread.
So what we practice in our adjuvant chemotherapy with the tip-based chemotherapy adjuvant for 4 cycle, and we also consider doing CT-RT post-chemotherapy. So that's a little bit over approach, but I feel that in CA penis, first chance is the best chance, because when the disease recurs, it recurs. So adjuvant chemo followed by adjuvant CT-RT.
Chemo followed by CTRT. So
Some cases we are doing, I think that's a little bit over and above, but what we have felt that adjuvant chemo definitely, that is the standard of care, and then we give CT-RT in
so
few
what
cases.
really is the role for adjuvant RT today, Dr. James? What do the guidelines recommend and what is it that we practice here?
When there are multiple nodes, extracapsular extension, pelvic node involvement, these are all very high risk features, which says that they are quite likely to occur, and we give radiation to such patients. Vedang has published
Dr.
data
Vedang
on-
will now scream at me if I tell this, but if you look at all the recommendations that are published, there is a role for adjuvant chemotherapy, but all recommendations, whether it is the EUA or the ESMPO or the AUA guidelines, all of the guidelines say that as of date, the role for adjuvant radiation in penile cancer is not there outside of a clinical trial. That is what are the recommendations. But having said that, I know Dr. Vedang has something to say.
2023, they came to their senses and they have said that adjuvant radiotherapy has a role now. EAU.
So so
Yes, it is Dr. Raval's paper. They refuse to include our
So would you
paper in
like to
that, and
incorporate
your-
chemotherapy first, radiation
I'll
first,
tell
or
you
chemoradiotherapy
I'll
first
tell you
together?
What we published a couple of years back is we looked at all our, I think, 125 patients for PN3. This is only PN3, mainly either pelvic node or ENE. And we found that intensification of treatment was the best. If you give, some patients got adjuvant RT alone, some got chemo alone, some got CT-RT. All the outcomes were similar if you didn't intensify with adjuvant chemo, followed by CT-RT. Small numbers, maybe some biases, maybe they were fitter patients, but they did the best, and that's what we tried
So
to
RT,
do.
what would be the field of RT that you would give? You would give to both the groins, both the pelvis, both the groin and the pelvis.
I think,
And Dr. Shivatsan, you've operated on this patient. What would be your concerns?
Wound concerns and lymphedema concerns and all those things. Plus,
I think they know it.
With IMRT these days, the toxicity is considerably less compared to the olden days.
So
when
first,
we-
what would be your field of radiation? Is it only the inguinal, or is it the iliac, or is it the ileal and
inguinal
inguinal?
and iliac, inguinal extended field RT. published
We
condom.
looked at this very recently. In one line, if there is a single node positive in one groin, we should include extended field. So we include the pelvis and other groin as well.
And if the pelvic node is positive, do you go
Then-
one station higher?
No. Then Amit Joshi's prediction is going to come true.
So they have published the even
Yeah,
the
I saw that.
radiation guidelines actually, the landmarks and everything field actually. And हमारा जो data था TMH का, in that the intensification group of patients was the one which survived maximum. The others who received single adjuvant, they died actually earlier. So that's important for everybody.
I think the bottom line is what Amit is also saying, we are all saying, there's only one chance. You do as much as you can, safely, there's only one chance the patient has got.
Fine, I think we are completely out of time. I had one more case. I think I overestimated my time
last
here.
1 minute.
Yeah,
is
so I'm
left.
not going to my next slide. I am going to skip my entire second case and I am going to just go for, so this was supposed to be a spotter. I thought we can have 2 cases and then 1 spotter. So this is the spotter. Dr. Markan, you had something to say.
Yeah,
So before we go to the spotter.
Yeah, I
and
think
go-
the point here, I think everybody has to take that message and it is loud and clear. The large volume centers which deal with penile cancer, I think now we're trying to give a guidelines like this. If you are going to do sort of extensive lymph node dissection, and if you find sort of one sort of single lymph node positive on one side, possibly I think these patients either can be observed or these patients can be given a consolidated treatment as Vedang is saying. There's one good chance of getting better. You can, not do radiation on the opposite groins. If you've done ILU inguinal on the opposite side, there is nothing there. Probably you can spare that groin. So the morbidity it is quite less. But if you want to consolidate the treatment, I think CT-RT is important because these the patients do extremely well. And I think we all centers in India who do large volume of CAPNE should come together, and then come out with these kind of guidelines because these patients are messed up.
There is one international study, I think Tata is going to become part of the impact study. That will give the answer of this sequencing and that has all 3 questions. I think TMS is going to be part of that study.
One observation which I have throughout the case and which is baffling to me, his primary disease is only grade 2,
Yeah.
which so much of...
True. Which is very unlikely. I agree.
I mean, exactly, grade 2...
Yeah, which is one of those cases.
Exactly.
So last question, just a spotter.
Sir.
So this is just one opinion from everyone. We are not going to discuss this in detail. Once one spotter, so I put them on an exam spot. They are going to say, and then I'm going to tell my impressions about it and we'll close. So this is a patient who is a middle-aged gentleman with small inguinal nodes, large bilateral inguinal nodes. What would you do for this patient? Chemotherapy first, radiation first, surgery first?
Neoadjuvant first.
No retroperitoneal nodes, no nodes anywhere else, no nodes in the lung.
In this scenario, neoadjuvant may be better.
Does everybody agree on neoadjuvant chemo here? Sir, we have a slide. Dr. Santosh. And I think we'll end with this.